Hi, everybody. I am Dr. Jennifer Goldin. I'm here in Orlando, Florida. I was diagnosed with CRPS back in 2011, and I am really grateful to be here.
Hi, everyone. I'm Dr. Agrawal. I have an anesthesia background, and then I did my pain fellowship at Cleveland Clinic in Ohio. And then now I practice in the Philadelphia area, private practice, and I've been working here for about a year and a half.
Yeah, I'm Robin Cohen. I'm a psychologist and a psychoanalyst from Los Angeles. And I've spent most of my practice, which is actually around 40 years worth, working with people who have some kind of medical or health problem, including pain and cancer. I also am one of the team associated with the California Pain Medicine Center. I don't know what the CMPC, Dr. Joshua Prager's multidisciplinary team, and I work with CRPS patients.
I'm Alex Escobar. I'm an anesthesia pain doctor at the University of Toledo. I also am in private practice. I've been working with CRPS patients pretty much since residency, and I really am fond of helping these patients out. I've found that the only way to truly move forward in the diagnosis and the disease process is to establish an interdisciplinary team that's there for them throughout the process. So hopefully can answer some questions tonight, and it look forward to an interactive event.
Hi, I'm Dr. Annie Layno-Moses. I'm physical medicine and rehabilitation trained, and then I did a pain fellowship over at Loma Linda. Currently, I am in private practice in Santa Monica, California, and I see quite a few CRPS patients in my practice. I've been out for about 2 years now.
Hi everyone, I'm Marisol Pérez and I am located in North Carolina. I'm a licensed clinical social worker and I provide individual counseling therapy to adolescents and adults in both English and Spanish, and I am also a fellow CRPS thriver.
Hi everyone, my name is Lindsay Reeves. I'm a doctor, I have my clinical doctorate in occupational therapy, so I'm an occupational therapist. I work at the USC Occupational Therapy faculty practice in Los Angeles, California, and I work with patients with a variety of chronic pain conditions, CRPS being one of them. And similar to a lot of other people, I work on an interdisciplinary pain team that involves a pain physician, O.T. physical therapy, and pain psychology. And I've presented on occupational therapy for pain management at a number of different conferences. So I'm so happy to be here today with all of you.
I'm Dr. Rasekhi, Roxanna Rasekhi. I am an anesthesiology pain management physician. I did my training at Mount Sinai West in Manhattan, and then I relocated to my home state of Florida, and I now work in Wellington and Lake Worth, Florida.
Hi, I'm Jim Scherer. I'm a physical therapist. I actually work with Dr. Cohen on the same pain team. I've been treating CRPS for 8 or 9 years. I love treating it. It's great to help people that are so disabled get back to their lives. And I work in Santa Monica.
Hi, everybody. I'm Shahin Sadik. I've been practicing pain management since 1993. My background is in anesthesiology. I'm in private practice. I see a lot of CRPS patients. I'm also on faculty of University of Southern California.
My name is Dr. Gutierrez. I'm an interventional pain management doctor in Austin, Texas. And I'm an anesthesia trained background before I did my pain fellowship. Did my pain fellowship up in Boston at Beth Israel Deaconess, Harvard Medical School, and came back to Austin, where I'm from, to join a practice. And I've been in the Austin area for about 8 years now. And I've been treating CRPS, or I guess I first learned about CRPS also my first year of anesthesia residency when one of my mentors to this day introduced me to it as she was doing research on the diagnosis and on some of the treatments available for it.
As the oldest person in the group, I can take a crack at it.
Okay.
I actually believe that I developed CRPS while I was in college, and I went into remission 2 or 3 times. I was unfortunately misdiagnosed. When I was in medical school, I had issues, and a doctor in medical school diagnosed me with CRPS. And from then on, I started thinking about how CRPS is treated, what are the symptoms, etc. And since then, I've been treating patients with CRPS.
Yeah. So it wasn't something that you really came across during, if it weren't for your personal experience, it wasn't something that you were taught.
That's correct. And that's very interesting because at least back then, and unfortunately still today, chronic pain and CRPS, they are sometimes not diagnosed correctly, and they are blamed on other things, whether it's psychological or physical or hypochondriasis, whatever you name it. And it's very important to have meetings like this so that the general public, especially people who do suffer from these problems, to know that there is help available to them, and there are wonderful support groups like CRPS Forum.
But to the newer doctors out there, do you feel like it's more in the curriculum now? It's something that's taught more frequently. You're running across it more?
Yes.
Okay.
Go, Nidhi.
Okay. I think that we're exposed to it earlier, but still fairly late in the game. I first came across CRPS as an anesthesia resident. We do some pain rotations, and I saw some patients that had CRPS. There's one patient that really stuck out in my mind at that point. It was like a young patient who had gotten CRPS from an infiltrated IV. And at that point where, I was placing several IVs all day, every day, it really makes you kind of stop and think about how even, every action that you do could have some sort of consequence down the road, and to really be aware of small changes that can happen. But to kind of the point that some of the others were making, it's not taught in medical school. I would say most other physicians outside of pain management or that have been exposed to it in some sort of pain-related rotation are not taught about CRPS. They don't really know much about it, have not heard of it, definitely do not know how to diagnose or know the features of it.
I couldn't agree with that more, Dr. Agrawal. And we share the common alumni at the Cleveland Clinic. I think pain in general is not taught during medical school and even during residency. And so the understanding, the pathophysiology, the treatment options are sometimes put into a large bundle, like a one-size-fits-all treatment. But really, I think it takes a team. It's always a multidisciplinary approach. There isn't a one-size-fits-all treatment. And to really understand it, you have to see a true diagnosis of CRPS, because I do feel like sometimes it's either overdiagnosed or underdiagnosed. And when you really see a case of CRPS, you'll never forget it. So Dr. Gutierrez, if you want to add to that, thanks for inviting me, and I'm happy to be here with you guys.
Yeah, thanks, Alex. Thanks again for doing this. So I saw my first case probably in 2010. But I think Dr. Escobar and Agrawal and I are all cut from the same block, and all believe in a multidisciplinary approach to this this very complex condition. And I do agree that pain isn't really taught in medical school. And it's certainly, I think, getting more attention now. Certainly in the past 5 years, I think it's gotten more attention. I do have medical students that do rotate with me now. And I do agree as well with Dr. Escobar that there needs to be a lot more attention, I think, brought to the primary care world, so we can get the cases a little bit earlier. I luckily am seeing, especially from the younger younger primary care physicians and younger general practitioners, general surgeons, orthopedic surgeons. I'm getting cases that are getting recognized early on, where we can really help people into a remission early. As we all know, the longer we allow this to continue, and the longer we allow the horrible condition to kind of propagate, it's harder to get into a remission. So yeah, I'd like to pass the mic on to anybody else, but that's my perspective on the attention it's getting, and I think it's a positive thing.
In physical therapy, we didn't really spend much time at all learning about it. We heard about it in class, but it was very, very, very brief. Now we're seeing a little bit more attention coming out on things like grid motor imagery, things like pain neuroscience education, stuff like that in PT school. But it's very, I think PTs now are able to recognize it as they're coming out of school, but they're still not the level of training we need, and that's being done more in continuing education courses and stuff like that. But those are starting to pop up.
I usually tell my families and my patients that it's a reactive nerve condition where there is a traumatic injury to a limb, and the nerves in that area are having a reactive response to the injury that's amplified to what a normal response would be, and that process then starts entering all the other systems in that limb, including blood vessels, other fingernails and hair growth and everything else. And it manifests as very severe hypersensitivity and burning pain. And it can wax and wane, but I explain it basically as a hyperactive reactive response to a trauma.
Anybody else have anything to add to that one?
Sure. I usually, tell my patients that it'll depend on the population we're talking to, whether it's, younger pediatric population versus older. But I essentially tell them it's a dysfunction of the central nervous system. A lot of people understand the central nervous system to be a fight or flight, sympathetic, parasympathetic, but there's also that freeze. So when the body isn't really sure what to do, it can have a wind-up phenomenon and sort of react inappropriately. And this is a real phenomenon. This isn't just perception. These are actually pathophysiological changes that are happening. In order to really understand the disease process, in a sense, it is a diagnosis of exclusion. So we have to make sure that we're ruling out other conditions. And once that's been done and they meet the criteria, we establish a diagnosis. I'd love to hear from Dr. Sadik, though.
Sure. I mean, excellent introductions, of course. If I may add, all these changes in the central nervous system and peripheral nervous system, as you mentioned, they cause havoc on the rest of the system in the muscles, joints, skin. They cause constant pain and burning that waxes and wanes, hypersensitivity to touch, and they sometimes also all this causes the entire body to change and for the entire body to be hypersensitive, even if you don't necessarily call this CRPS of another part of the body. It a lot of times affects the rest of the body as well.
Yeah, I think that's a really great message to give people, because I know that when I was first diagnosed, that was not a message that I was ever given. And I think that's a really great kind of expectation to give people and their families, like just kind of a heads up of this is what to expect and to understand what's going to happen. I think that was my biggest take home from being diagnosed with something like CRPS, is that I never really got a full explanation and a kind of what to expect, like a reality check of what to expect from this illness and kind of a, hey, look, this is going to be really bad and we're never going to make it 100% better, but here's what you can expect and here's what you can expect from your body. So I think, you know, having patients understand that is really important. Yeah.
One thing that I would like to add is that I share with other providers or other mental health providers is that it's not psychological. There's such a big stigma. And so, yeah, a lot of the work that I do consulting, when other providers are consulting with me is really making this clear, because that in itself can be a traumatic experience for those of us that have CRPS, having a provider, you know, really push that we're, you know, this is a psychological experience, and it's not.
It's interesting being on the physician side of it and going to your pharmacy and getting, being treated as a drug seeker for narcotics, or having to show up at a physician's office with all of your testing and them not even looking at it and thinking you're crazy. It's a very different experience to experience from the physician side and from a patient side when you're dealing with chronic pain. It's a real eye opener. It definitely is. So yeah, so when you tell someone that a smell makes your pain worse, I know how crazy that sounds. And I know what it feels like to have someone look at you like you're insane. Yeah, so it's a very—
Dr. Goldin,
Mm-hmm.
the same goes when patients actually see a provider who truly understand the disease process. I feel like this sort of look on their face, like they've finally, you know, met the sort of magical, you know, fix that's going to happen. So setting the expectations critical. But I think that there's two ends to it. There's those patients that feel fearful when they go to a clinic to not really know what to understand, and then, or what to expect. And then when they finally meet someone who truly understands it, can kind of be the captain to direct them into the right locations. It's truly, you know, breathtaking to when you see that change and you see that hope in the patient's, you know, face and the family's face. It really makes a huge impact on the reason why we do what we do.
Oh, it's absolutely amazing. And that's why seeing this many people who know what it is just absolutely amazing. Like it fills me with so much hope. And that's why I hope everybody who's watching is hopeful, because like just seeing everybody nod their heads when I said, oh, a smell makes my pain worse. Everybody's like, well, yeah, like that fills me with so much hope. So it's exciting to see that, for me at least.
So CRPS is basically diagnosed based on clinical symptoms and the physical exam more than anything. There are a few tests that you could do, but whether they're negative or positive, they don't tell you whether the patient has CRPS or not. CRPS, generally the biggest thing in a patient with CRPS is that constant high level pain, the constant area of the body that whenever touched, it hurts when it shouldn't hurt. Sometimes that area of the body gets cold, sometimes it's hot, sometimes it's swollen, sometimes it gets red, sometimes it gets blue at different stages. It can stay blue or stay red. But most of the time, or I would say more than half the time, you can find an injury that happened to that part of the body. A lot of times you don't. It might have been a minor injury in the past, or an injury that you never really felt, but it caused the nerves to go haywire, produce inflammatory changes, and start causing muscle atrophy, and the temperature changes, reduce blood flow. So to diagnose CRPS is basically a history and physical exam phenomenon.
So what makes us start to think about CRPS is when we see patients that have extreme pain that's out of proportion to their physical exam or their injury, and they also have autonomic dysfunction on top of that. In 1994, the International Association of Pain got together and they decided that they were going to come up with criteria specific for diagnosing CRPS, and they called it the Budapest Criteria. And so in order to properly diagnose patients, we're looking for symptoms in 4 different categories. It's sensory symptoms, so that can be hyperalgesia or allodynia, abnormal sensation or increased sensitivity to pain. We're looking for motor changes, so sometimes that's loss of range of motion of the certain area. We're looking for pseudomotor changes and also vasomotor changes, so any kind of edema of that area or any loss of hair growth. And the problem really is not that, the problem is you have to think of it. So we are taught it in anesthesia residency. It is part of our training. CRPS is on our boards. And then again, when you do pain medicine fellowship, you see it a lot more. But the problem is you learn so many things. And if on that day you weren't with that in your mind, you may, as a primary care provider, see a patient that has some unusual symptoms and just say, well, I'm not sure, or just see if it goes away, or let's send you to another specialist. So it really needs to be like fresh on the provider's mind.
Dr. Rikishi, I can't, that was a perfect explanation of having actual criteria to identify and properly diagnose. I can tell you that there are 2 types. So we know type 1 and type 2. And what we know about type 2 being a causalgia experience, you don't have to have all the Budapest criteria present. I can tell you, not only do you not need Budapest criteria, it doesn't always present at once. So a lot of times I fight with insurance carriers, I fight with workman's compensation and providers that they say this patient doesn't meet the criteria, quote unquote. And I argue that because I always have my patients keep diaries. I have my patients take pictures, making sure that during the different phases that they experience, we're able to capture that, because when you come to the doctor's office, it's always a misnomer that everything is, fine and nothing hurts. But when they leave, everything, really accentuates itself. So we just have to make sure that we understand and we make sure others that CRPS is not just based solely on criteria, and it is an ever-evolving disease state. So just because a patient presents, it doesn't have all of the features or all of the classical characteristics, it does not mean that it's not CRPS.
So Dr. Escobar, you had mentioned that CRPS is a diagnosis of exclusion, and it definitely is. And I think some chats are coming in here, but you always want to make sure that as a physician, the pain isn't coming from something else other than CRPS, like a cervical radiculopathy, so like a pinched nerve in your neck. So you make sure you want to get an MRI or CT scan, maybe get some x-rays. Also, you want to make sure that the nerves are functioning a certain way. So you might want to get a nerve conduction study or EMG. In my clinical experience, a lot of patients are coming to me after having CRPS for at least a couple years, 4 years or longer. So they've already had a lot of these tests done. But even just routine blood work, making sure, I think someone commented on Lyme disease, making sure there isn't an inflammatory disease or rheumatological disease. And then also potentially some vascular studies, making sure that, there's no D.P.T, there's no vascular issue that's going on as well.
Just to add one more thing to what everyone's already kind of spoken to, if sometimes the patients don't present with all the kind of classic criteria all at once, and if you can't find another cause, anything else to kind of exclude it, a lot of times a procedure or a block can help kind of tease out to see if this is kind of that CNS mediated pain. And so that's something about patient expectation and kind of your initial visit, and you kind of lay out the roadmap for them that this, there might be a procedure that not only could be therapeutic and help their pain, but also help in the diagnoses of the problem.
And to build off of what Dr. Agrawal says, unfortunately, sometimes we have CRPS that is not mediated by the pathway of that block. So again, it's very tough because there's not a set like MRI or nerve study, or we have no tool to diagnose CRPS. So really it comes down to your physician's experience and your clinical history. So it's important to all our patients that are on right now to be as thorough as possible when you go see a neurologist or a pain physician about how your pain started and what you've experienced since that time, how it's progressed. And a lot of features are important, like we talked about, that because there are criteria that we go by, but unfortunately that's mainly for your workman's comp and for insurance purposes. But it's important to just still tell us everything you've experienced, because there are atypical presentations as well.
If I may add something else, a beautiful discussion here. A lot of times when CRPS happens in an area of the body that's well vascularized, let's say in the knee area where there are a lot of the arteries running around, there is no end arterioles where it's the end of the vascular system, like in the hands and the feet. In the hands and the feet, the color changes, the coldness, the swelling, everything else is much more obvious. But when it happens in an area like a shoulder or a knee, it's much more subtle and it becomes much more of a diagnosis of exclusion to say that the patient has CRPS. Why? For many reasons. One reason being that the area is getting good blood flow, and the signs you see on looking at the area are not necessarily the same. So it's not always that the CRPS does not always present as a classical presentation.
So as occupational therapists, we are particularly interested in looking at how any health condition like a chronic pain condition is impacting a person's ability to do the things that they want and need to do every day. And so occupations is a little bit deceiving because we're not just focusing on work, but really anything that takes up time in your day, we consider to be a valuable occupation. And so we kind of take a comprehensive approach to looking at all areas of your life and seeing how CRPS is impacting that. And in my practice, we use a specific approach called lifestyle redesign, where we're really looking at people's habits and routines and how those things are either health promoting and helping you kind of cope and live with pain, and also strategies for reducing pain. Or how those daily routines and habits might be health deterring. And so we work on making small, sustainable behavioral changes in your everyday life that can help to cope with the pain. So examples of that are looking at sort of, activities of daily living like sleep and eating and exercise routines. We do a lot of work around stress management and self-regulation strategies. There's also a lot that we do with activity pacing and energy management. I think my talk was recorded yesterday on fatigue and energy management specifically, as well as things like adaptive and compensatory strategies, ways to reintegrate back into the community. We work a lot with patients on advocacy and self-advocacy efforts. So things like work accommodations, school accommodations, things like that. And again, our whole focus and purpose is on function and getting you back to the things that are meaningful and purposeful for you.
Wow, yeah, that's really, really helpful. And then Dr. Cohen, how does your role kind of play in with like what Dr. Reeves was speaking about?
I'll just talk in general about my role, because it kind of has tentacles in every direction. But in my experience with CRPS patients, there's two issues that are very important, which are, one, they have this extreme pain syndrome, and two, as a result of having CRPS, very often they're also living in a state of trauma. To have such severe pain can be traumatizing. To have the disabilities that they often have is traumatizing, and all the losses that go along with that. and also to go through the process that many people go through in terms of trying to find somebody who understands what CRPS is and somebody who's able to diagnose them. There's a kind of a history of trauma that people are experiencing who have chronic pain, but particularly, I think, CRPS. So what I try to do is work on the one of the main things is kind of the activation of the nervous system. CRPS, chronic pain itself, but also particularly CRPS, are very activating of the nervous system, and trauma is activating of the nervous system. So, and you see when people first come to you, they're like this, you know, they're emotionally dysregulated. So what you want to do, I think the most important thing to do to start off with is to try to help them kind of stabilize their nervous system with things like meditation, relaxation training, hypnosis, sometimes EMDR. I really liked, I saw the end of what Marisol was presenting. I wish I had seen the whole thing because you seem to be covering some of these techniques and it was fascinating to me. So that's the first thing that I would do. And then also working with people like Dr. Reeves and like Jim. I work with Jim every day, and other people on the team in trying to help with them, the person understand what, you know, really to start processing what's happened to me and what's going to happen as a result of finding this treatment, and what's my life going to look like from here on in, and helping them kind of develop coping strategies, ways of thinking about it and processing all the feelings and experiences that have gone with having CRPS. And I think that's all I have to say for now.
No, I think that's really great. I think that's a really important aspect that we don't think about a lot of times. Yeah.
Can I just say one more thing?
Oh yeah, sure.
I think most multidisciplinary teams know this already, but it's really helpful to have a psychologist. It's helpful to have everybody on the team, but also a psychologist, because, you know, if someone is living in a state of chronic pain and dysfunction and disability, and then they get a treatment, you know, whether it's the physical therapy, ketamine, all the different treatments that they get, and they get physically better. If you do not treat the brain and the mind and the psychology, that part is still going to be kind of stuck in the place where it was before the medical treatment that increased the pain, because pain becomes, you know, part of the nervous system and part of the brain and part of how the mind functions. So you need the psychologist involved to kind of work with that aspect of it.
Having a psychologist involved is not only, you know, a good thing, it's imperative. So Dr. Cohen, thank you for that, because it's critical.
Yeah. Yeah, I think it's sometimes something that we often overlook and forget. Yeah.
Absolutely. I had a case just last month that we were struggling with, and she really started turning the corner after we got a psychologist on board, and helped with everything, helped with outlook, helped with the positivity and continuing all the therapies. And we're finally gaining some ground on it. And I really attribute it to the help we've gotten her with the psychologist.
I can take this. You know, I can hopefully try to break some ice with patients that, you know, regardless of your preparation or not, you know, you want to just make sure you're seeing the right provider. You obviously can help things having, you know, all of your details of the, you know, the previous treatments you've had done, the previous testing you've had. Obviously, any pictures or imagery to show the dissimilarities and extremities, if that is the principal area of your pain. But fear not that you have to be prepared and equipped to sort of establish a diagnosis before you even enter the room or enter, the building. Pain needs to be treated as a holistic disease process. And so going anywhere that has a multidisciplinary approach is critical. Obviously, these testing and previous diagnoses and treatments are important. However, just because you don't have that doesn't mean you're not going to be treated in the same fashion that you would if you seek the right provider. So we can't stress that enough, that you really want to seek the right location and provider, and a lot of your worries will be at ease.
I agree with Alex. The more prepared you can be, the easier it is sometimes for us. I know it's difficult to summarize a lot of information and also summarize all the providers you've seen and tests you've had done. But specifically, if patients could think about what they've tried before and if it was efficacious or not, sometimes that's where we end up with like trouble, because we're trying to decide whether we want to try something or if it was truly a failure or if it was a failure for some other reason. Once we're treating the patient, I think the most important thing is to keep some sort of pain journal, because once you get in the doctor's office, you tend to forget exactly what was bothering you, where it was bothering you, how it's changed since the last visit. So that kind of thing could make things easier visit to visit.
Excellent. And if I may add, it's very important for you as a patient to do a few principal things, general things, like bring the list of your medications, your surgeries, your medical issues that you have, previous treatments you've had, previous surgeries you've had. All of this makes the pain physician focus more on your CRPS or chronic pain situation, rather than trying to get the comorbidities, all the other problems that might affect your treatment and your situation. So the more you can give your doctor a general overview of your health, what you've taken before, what has worked for you before, what makes the pain worse, what makes the pain better. That's what generally a physician needs to have.
I wanted to add to the pain journal concept from a physical therapy perspective. I often like them having like an activity journal and keeping track of kind of what their activity level is. It also gets them, sometimes we get a little too focused on pain and people are a little hyper vigilant. So I find that if they're focused on what's their activity every day, what are they able to do, they're able to see progress a little bit better. And they might actually see the change there before they see a drop in pain, which is important for them.
Totally agree. Totally agree.
Dr. Scherer, I mean, when you said that, I mean, so many things came to mind. And to add to that, so the activity journal is huge. I also like to talk to patients about their goals and what they previously liked to do, because what is critical is that we are restoring function in these patients. And our visits go so much differently when we can talk about what the patient enjoys and what they miss doing. And if we can offer them the hope that we can potentially get them back to those activities, I think those visits go much more effectively than just focusing primarily on the pain. So I agree with all of that. Thanks.
I was going to add to that from an occupational therapy standpoint too, getting patients involved in tracking and building awareness. That's really helpful for supporting behavior change. Behavior change is really hard. And so when they start to notice those patterns, and that kind of encourages them to maybe try to do things differently or avoid certain things that they've recognized as triggers, and do more of the things that help them alleviate their symptoms. Instead of me telling them to do that, they're going to build that awareness on their own, which is really helpful. And I think the other thing that I do a lot of in occupational therapy treatment is for doing symptom tracking and going into a healthcare appointment, that can be really stressful for patients. And so we'll do a lot of work around how to best prepare for appointments and how to communicate their needs effectively with their physicians. That sort of assertive communication training is another skill that we'll work on with patients, which is so important for their physician relationships, but also being able to communicate with family members, colleagues, whatnot. So, yeah.
Marisol, do you have anything to add as far as how patients can prepare better to come in to see you and what would be helpful?
So to be honest, with therapy, I use a trauma-informed approach. And so for some people that word can be triggering. So I just invite my clients to show up however they like. You know, we just kind of check in. So everyone is different. Some of my clients prefer to have a list on the different things that they would like to cover for that session. Some don't. Some have an idea of where they would like to pick up on, and some don't. And so we just kind of meet the person where they're at. So that question, it doesn't really apply with my style.
Yeah, no, that makes sense. That makes sense.
I'm sorry to be the one that's always interrupting, but so many good ideas are brought up. And Marisol, you know, just like you mentioned about sort of this open-mindedness that the provider needs to have, the patient needs to have that as well. So I know Dr. Rasekhi, did I say that correctly, Roxanna?
Close enough.
Okay. You started to imply that, you know, a lot of people come in with preconceived notions that treatments that they underwent that failed sometimes is either poor technique or poor timing, you know, improper diagnosis. So all of these things need to be sort of put on the table, understanding that the provider has to be open-minded, but the patient as well. Come with an open mind and understand that, you know, different timing calls for different treatments. So just because something didn't work in the past doesn't mean that it won't work in the future.
Absolutely, Dr. Escobar. Part of my style is really meeting the client where they're at, because when we're having a trauma-focused approach, we want to have choice available. I'm not sure if you were able to join some of the orienting that I did, but it's really, for therapy specifically, it's really including choice language, you know, really being intentional about the language that we're using. Hey, you know, are you interested in doing this? Maybe you are, maybe you're not. Because when we're thinking about trauma in a traumatic experience, especially with CRPS, we don't have a choice. And so in choice making, the body then becomes relaxed, it becomes regulated, and then we then feel like we have autonomy in making certain decisions. And so I try to be really mindful in being invitational with some of these things, and not necessarily personally like just putting it on the table. It's more invitational language and choice as far as like my therapeutic style.
Which I think is a really great question, because I think when I first was diagnosed, my idea of remission was life goes back to normal and everything's great.
It's a new normal, isn't it? It is a new normal, isn't it?
Yes.
The term's thrown around a lot this year. Yeah, I'll let you and Dr. Sadik, who experienced it firsthand, tell us what it means to you guys. And I'm happy to tell you what I usually counsel my patients about.
Go ahead, Dr. Sadik, what do you think?
It's an interesting concept. Thank you, Doc. But yes, you can go into remission like any other situation, and remission may mean a normal situation, or it may mean that you're just better. In general, CRPS, once you have it, it lurks behind the scenes looking for an opportunity to raise its head. But remission can happen. Remission is good. Sometimes remission happens with good treatment. And if you stop the treatment, or you stop the exercises, or you stop the relaxation techniques, whatever your thought, it can come back. So you want to think of remission as a situation where you are much more comfortable with the situation you are in. And there are many different levels of remission.
leave it to me to interrupt again. I think when I look at remission, I can't echo those sentiments, Dr. Sadik, is that there's different phases. And I usually look at it as a psychological remission and a physiological remission. So a lot of times we see, the disease state improve, blood flow to that area improve. And so the hypersensitivity, the swelling, the allodynia that the patients experience, a lot of times gets better. However, if the psychological component hasn't been addressed, then that disease state is not in remission. So both of those have to sort of coalesce and meet together to find the true remission. And just as you mentioned, Dr. Goldin, that's different for everyone. I think the stabilization and the lack of acceleration of symptomatology is really where we find remission. And that's sort of that new normal that Dr. Gutierrez alluded to.
Yeah, I love that explanation, actually. That I could see that paralleling in my life exactly. Like, to me, remission is I can walk outside in the rain and not scream, or and not be so fearful of the pain recurring and being at a level 10 anymore. Like, I have a much more functional life, but I can't go back and do the things that I used to do, or I will be in that level of pain again. Yeah. But from my old medical understanding of remission, I thought it just meant it was gone. But
and
now
I think so many patients talk about their high pain tolerance, and I've never seen a higher tolerance other than laboring and delivery than my CRPS patients. I mean, what they deal with and what they tolerate is truly impressive. And so sometimes we just like to tell ourselves that we have a high pain tolerance, but truly that sort of level of remission is still patients that are reporting VAS scores of 5 to 6, which to a normal individual would be not enough or not sufficient to continue their normal day-to-day activities.
I'd also like to hear from some of the mental health experts here about acceptance, because there's remission and then there's the level where the person's like, okay, I am okay where I am, because we can't get everyone better, we can't get everyone out of pain, but we can get most people to a level where they can accept it. And I think that our social worker and Dr. Cohen can speak to that a little bit more. But I think that that's really important, not just going for remission, but also going for this is your life, and you're going to get back to your life, however that looks.
Absolutely. I appreciate you mentioning that. It's sort of getting to know this new part of ourselves. And so getting to be in relationship with the body, going through the stages of grief, which is totally normal and understandable. And then landing on acceptance. And sometimes, if I'm having a bad flare-up day, I may go back a little bit, in my stage of grief, which is totally understandable. But part of it is really gaining some coping skills, really setting a strong foundation, so that way when these moments happen, we have these coping strategies to resort to help us. And as I mentioned in my presentation, just building a relationship with yourself, going inward. This is a very inward experience, and the inward journey is lifelong. And so, yeah, I appreciate you mentioning acceptance, because that's absolutely a part of it. One thing I forgot to mention is that in order to sort of get to acceptance, it's important to process the trauma and use specific modalities. It can be, as Dr. Cohen mentioned, it can be EMDR. It can also be bottom-up approaches like sensory motor psychotherapy or somatic experiencing or brain spotting, so that we can process the trauma to then get to acceptance. That's also a very important component.
I think, in addition to what Marisol said, I think part of what helps in terms of processing, in terms of getting to acceptance, is trying to help the person, given where they've come to in their treatment, trying to help them visualize what their life is going to be like, what their life, really get them to see who they are now. And that, I think, helps with acceptance, having a very clear picture of who they are now and also what their life is and what it can be, I think helps with developing acceptance. What does it mean that I may have some pain for the rest of my life, even if I'm doing a lot better than I was. Sorry about the dogs. Even though I'm doing a lot better than I was before, what will my life look like now? I think that really helps the person move towards acceptance.
What we are learning from all this beautiful conversation is that, remission and acceptance in CRPS and chronic pain is different than remission, let's say, from cancer. Sometimes with cancer, you have a blood test, look at the cancer markers, look at the MRI, see if the tumor has grown, etc. Remember that CRPS is something that the patient has and the patient feels, and it's based on the patient's level of understanding of how well they're doing, how much they've accepted. So, our job, especially the psychologist's job, is to, help them achieve that, to see what is the goal you want. The occupational therapist, the same thing. What are things that you want to do? You might at different levels call that a remission. There are very few ways to objectively otherwise measure remission. I know there is a lot going on, but the specifics are variable. I can't think of something brand new that may be coming up in the near future. Maybe other members of the panel do.
I think the pillars of treatment are still, I'm sorry, am I interrupting somebody?
No.
I think the pillars are still the same principles of treatment, but they're getting a bit better. And I know there was a talk earlier today on neuromodulation. That's one field where when treatment for CRPS has really made leaps and bounds in the past 5 years. These days now we have more tools in that treatment category that leads to more profound improvement in symptoms and in more long-term remissions. One of them, which I'm sure was spoken about earlier today, is dorsal root ganglion stimulation. That one's really made the biggest impact. It's been the biggest gift to my practice and my patients. There's also improvements and advancements in peripheral nerve stimulation in the past few years that have also really made a substantial improvement in what we've been able to offer our patients. Even when I was in fellowship 7 years ago, that treatment category has really made leaps and bounds.
I can
think
start.
when you talk, please, Dr. Agrawal, please.
I think just to really kind of reiterate what we've already been saying about early diagnoses. And so the earlier we do diagnose a CRPS correctly and begin treatment, the patient has a higher chance of going into remission, higher chance of avoiding spread. Another thing is patient expectations. So if you kind of lay out the roadmap, kind of educate them that this is a possibility going forward, and that if their symptoms are well controlled, doesn't mean that they cannot come back or it might not spread to another body part. And so to educate the patient that they should be mindful and kind of vigilant to recognize any symptoms when they do appear.
One of the things that me and Dr. Agrawal share is training at the Cleveland Clinic. And during my time there, working closely with Dr. Stanton Hicks, I can't tell you enough how many times he's been able to properly identify sort of a crosstalk or traveling or spreading CRPS. I think it's very easy to attribute other symptomatology to CRPS spreading. However, that's not always the case. I think what we found with neuromodulation is when you treat the initial pain generator, typically a lot of those other symptomatologies do improve. So things like dorsal root ganglion stimulation, when we talk about research, we have some of the strongest research to support that with the Accurate study that demonstrated dorsal root ganglion stimulation being superior to low frequency stimulation, which has been the cornerstone of this treatment paradigm for years. So truly identifying a proper diagnosis of a new symptomatology and not just quickly labeling it as spread of CRPS to another location. However, we do know that this does occur. So again, proper diagnosis is key.
And to piggyback off of that exact topic, you know, once it has spread or we believe it's spread, a lot of my patients will ask me, well, what am I going to do about my left foot? You know, it started in my right knee, but now it's everywhere. You know, and one of my mentors taught me a long time ago, and it still holds true in my practice, is you treat where it began, not what it's become. And that is how we can help control the symptoms when it has spread or we believe it has spread.
It's interesting from a physical therapy standpoint, sometimes we actually start with the area that's less irritable and the place that went last, because we're not going in there to inject the area to decrease the symptoms there. We're trying to get motion. So if someone has hand CRPS or something like that, you know, I'll start with the shoulder. I'll start with the neck, because I can get my hands on there and mobilize those areas a little bit, and then I don't flare up the hand. And then I'll do mirror box or something like that with the hand. So we'll actually start kind of on the opposite, on the less severe areas, and just kind of calm that all down and get to the more severe areas as it kind of unwinds a little bit.
Yeah, and I want to make clear, I was only talking about neuromodulation. I wasn't talking to make sure that it didn't come off the wrong way.
Even things like, you know, sympathetic blocks. So just like you're mentioning, when patients have hypersensitivity, it's extremely difficult to, you know, manipulate that area. So when we offer things like stellate ganglion blocks and sympathetic blocks, we're trying to improve, you know, blood flow to that area, to desensitize that area, to allow our physical therapist to work with it. So yeah, that's a great point, that you can't go straight to the source when you have to be hands-on and manipulate. However, if we can work together to minimize the allodynia that they experience, you'll be able to get to that distal extremity. So great point.
I know this is like often people are searching for natural supplements or things that patients on the internet or other support groups recommend. So I'm just curious if there's anything standard that people recommend that patients with CRPS take.
We typically recommend, go ahead, doctor, please. I'll jump in at any time. So
I don't have anything in particular I recommend. There was a study that suggested that vitamin C might be helpful for its antioxidant effects in preventing CRPS after surgery. And so then there were other studies after that sort of refuted that. But because it is such a low risk to take 500 milligrams of vitamin C, that's something I would suggest to patients if they were going in for surgery, because there's no really harm of doing it.
And that's for
sorry, somebody's asking. It was actually 500 milligrams of vitamin C for 50 days. That's what they studied. Somebody in the chat.
And that's for patients with or without CRPS, just if you're going in for surgery.
With or without.
Okay.
Mm-hmm.
Yeah, and to my knowledge, there's some like studies that have shown some benefit in very early diagnoses of CRPS, but if it's recognized pretty immediately and within the first few months, if they start taking high dose vitamin C, but most of these patients are not presenting that early. And so at later stages, there's less kind of convincing data that would help.
And
one of the things that we see a lot of times is other diagnoses, such as autonomic dysfunction symptoms like POT syndrome. So, you know, utilizing techniques that also help benefit those types of disorders. Recumbent bicycling has been found to be extremely effective. I know we're talking about supplements, but I think vitamin C is something that I'm a huge proponent of, especially during flares. As mentioned, trying to scavenge free radicals to diminish oxidization on lipid membranes, and again, being low risk, not to be used for long-term treatments, but definitely the acute phases. And then obviously the cornerstone of CRPS being desensitization and physical therapy.
It's kind of
Many patients don't benefit from ice. However, I have had very few patients tell me that's the only thing that helps. But typically and traditionally speaking, heat seems to be more effective than ice. Dr. Sadik?
Yeah, I fully agree. Majority of the time, ice can make things worse. Especially if you are in this late phases where there is not much blood flow going on. But what I would say is go with the symptoms. If it helps the symptoms, reduces the sensitivity, reduces the pain, then that's okay. Majority of the time, the ice causes more pain, and therefore it might increase hypersensitivity. But if it doesn't cause more pain, you can use it. Cold does not, cold temperature generally does not harm parts of the body as much as high temperature, as long as it's done on a limited basis. CRPS per se there is no known mechanism of CRPS starting in the gastrointestinal symptoms. I imagine though it may go there because CRPS can cause global issues. We do know that the gastrointestinal system has its own nervous system, which is the visceral nervous system. It's a little bit different than the somatic nervous system, which is pretty much the rest of the body. In short, yes, it can, because it can cause hypersensitivity. On the other hand, it's very difficult to prove and diagnose, and you need to be careful. Having said all that, a person with hypersensitivity or gastrointestinal tract who has had good workup to make sure there's nothing else going on, the treatment might be very similar to, at least medication-wise, to other types of CRPS.
Yeah, and I know I've seen some people talk about CRPS in their bladder, in their pelvis, and that kind. So I would assume it's kind of similar to the gastrointestinal system.
I think what's difficult, so abdominal CRPS has been something that we have successfully treated with celiac plexus blocks and neuromodulation as well. However, I think it's critical, being a diagnosis of exclusion, that the abdominal cavity has many organs that could be of dysfunction. And what we know about CRPS, being able to identify in the periphery to see some of the somatic and autonomic changes that occur, it's very difficult to appreciate in the trunk or the core. So when patients describe, because a lot of times I'll ask patients, where do they feel pain? They'll say my SI joint. And I said, no, show me, point with your finger, where do you feel like it hurts? So, or patients will say my L5, they know they have a bad disc, so they say it's their L5. And I'm not asking them the anatomical structure of where their pain is. I'm asking them where they experience or feel pain. So it's very difficult to appreciate a difference between pain, that's due to abdominal or GI distension versus some inflammation or sort of suprapubic fullness. That can be sort of difficult to tease out. So just like Dr. Sadik mentioned with visceral hyperalgesia, we usually treat that as the primary source once everything else has been ruled out.
Okay, so I'm reading now some questions from the chat, and someone asked a question about their 11-year-old, and they were asking for a recommendation for a good pain journal for an 11-year-old. They don't want her hyper-focused on the pain, but they definitely want some type of pain journal for an 11-year-old. And I was curious if anyone had any recommendations. Like, I know I used an app on my phone. I'm curious if anyone has a recommendation for someone who's 11. Is there an app or a specific journal that anyone likes and recommends?
I don't have a specific suggestion, but first, bravo, you're a wonderful parent because you're thinking about your child as to what is the best way for them to express their pain and feelings without unduly stressing the pain and constantly thinking about the pain. So it has to be in an 11-year-old's language. It has to be based on their feelings, what they feel, what were they doing, etc. I do not know any specific types of diaries though, but it's pain journals in general should focus not on just pain, but activity, what the person was doing, what happened, and how they felt about it. If you just do it based on level of pain, it would not be successful.
To add to that, it may be supportive for the parent to keep track of everything and the parent to sort of do the checking in with the child. Maybe have like a visual, just like a visual checking in that the child may collaborate in creating in a poster board where they have different checking in images of emotions, different pain levels, and the parent then can be the one to actually keep track of everything versus that burden sort of falling on the child. That might be a helpful suggestion.
Great idea. Yeah.
I can recommend several pain apps that are pain logs, and whoever asked for these can check them out and see if they fit for their child. Should I just write that in the chat, or should I say it?
I guess if you want to go ahead and say it, and then
Okay.
that would be a great idea.
Sure. So one of them is called Pain Log. These are all on an iPhone. I don't know if they're all on Android too. Pain Log. Another one's called Pain Care. And the other one's called Pain Tracker. And I don't know, it says Pain Tracker. I can't read the full thing of what it says. And so check them out. They have different different aspects that might be appealing to a kid. Some might be more appealing than others.
Chronic pain trackers, that's the one I use on iPhone.
What is the one you use?
One it's called Chronic Pain Tracker. That's
Oh,
the one
okay.
Yeah. Okay, so the next question is, what mental health resources and coping strategies do you recommend for people with CRPS?
Well, one of the things I do, in addition to the things we talked about earlier, is I try to get them to imagine issues that come up in the future. So if, let's just say somebody is afraid to really talk about her pain with her friends or with her family members because they're afraid of someone saying it's not such a big deal, you look fine. They're afraid of not having someone respond well. We kind of imagine the different situations of them communicating to different people and how they would handle all of those things. Or if someone is going to be going to work and they're afraid of their supervisor not being sensitive to their needs, how would they deal with that? So we do a lot of that to try to have them imagine what it's going to be like and how they can deal with it, so they really know, because there's so much worrying that goes on. What's going to happen to me in the future? If they feel like they will have skills and abilities in the future to handle these things, they don't have to obsess about it and be worried all the time.
Some other strategies may be grounding. I did a support group on CRPS forum, so the grounding is there if you all want to check that out. In addition to grounding, what's supportive of grounding is that it helps you be in the here and now. versus ruminating on the future or the past. And also boundaries. So I didn't talk about boundaries in my presentation, but boundaries are critical, not only with ourselves, but with others. So I like to call boundaries healthy limits. Sometimes boundaries, there's like a stigma around that word. So setting healthy limits, you know, healthy limits around time, physical healthy limits around our emotions, you know, around our thoughts, our spiritual beliefs. There are just so many ways to set healthy limits with ourselves and others, and keeping in mind of what's in our control versus what's out of our control. We can't control other people's thoughts, emotions, behaviors, actions, but we can control our own. We can control how we're going to cope with how we're feeling. So sometimes that's also a helpful strategy.
Dr. Scherer, do you have any? Oh, I'm sorry, Dr. Reeves, go ahead.
Yeah, that's okay. I think both what Dr. Cohen and Marisol kind of speak to goes back to the importance of communication and knowing how to communicate effectively. And similar to what Dr. Cohen said about like preparing for stressful events, we would do some like role playing in occupational therapy too, to actually practice what that conversation might feel like and sound like. And then I think, you know, there's so many stress management and self-regulation strategies in addition to things that people have already mentioned, but learning how to avoid or adapt to situations, sensory strategies as a way to cope with the pain. And because our focus in my practice is particularly on habits and routines also, just thinking about daily healthy habits, exercise, how is your sleep routine, having these regular routines that are kind of calming and regulating for your nervous system. And then I think what we're doing here today is a great example of how to cope with pain, building those social supports, having a community and staying connected to people that are also living with chronic pain. So I think connecting people to those resources is also really important.
Leave it to me to interrupt, especially while we're hearing the dogs barking. I think one of the most important things is to understand that when you have a medical condition, that not everyone needs to understand that medical condition. I think what we're doing with these forums is really bringing more awareness to the diagnosis to make it less stigmatic. So I can't stress that enough that, you know, when you're having difficulties, with your coworkers, with friends, you don't have to get too detailed about, I feel like a lot of times patients think that they need to prove themselves. They need to really make sure that everyone believes them. And that's not the case. Now with your loved ones, it's a different story. I think that there is an element to support and sort of that group therapy that they need to be aware of. However, understand that with disease states, you don't have to explain yourself to every single person you come into contact with.
Yeah, that's good advice.
Something else that may be supportive is that not everything is going to be helpful all the time. And so the checking in part is really important. You know, we have so many different tools in a toolbox, but for example, I have my singing bowls back here. My singing bowls may be supportive for me this week, but maybe not next week. Maybe next week I have to sit out in nature, or maybe next week my drums that are behind the screen are going to be more supportive. And so really just checking in and having different things can be helpful. Another strategy can be actually creating a calm down box where you have either reminders or different things like smells. I have my cedar wood here. So just different things that you can have easily accessible for you can also be helpful.
Well, I tell them stories of success that I've had with other patients just like them. I think that encourages them, especially when they're coming in having this weird diagnosis that maybe nobody else understands or believes, and they're seeing someone like me that sees it every day. And I tell them a lot of what my success stories have been like, and that there are remissions out there. You can get better. So that's how I do it. I have my own story. I don't have CRPS, but I've had 3 neck surgeries for a nerve issue that I had from a compression in my neck. And I tell them, a lot of what they're feeling, in establishing a new normal is similar to what I've had, although I don't have the same diagnosis. I kind of show them that with dedication, staying positive, and going through all the necessary treatments, you can have remissions, and you can lead a happy, healthy life and do the things you still love to do, like many of my patients have.
Yeah. How about you, Marisol?
For me,
Go ahead, please.
For me, it starts with my practice name. My practice name is called Peaceful Counseling and Therapy. And that was really intentional for many different reasons. And so, yeah, it starts with that, as Dr. Escobar had mentioned, setting goals in the beginning and then keeping track of our progress. And once we start keeping track of that progress, the progress itself is evidence of that hope, that there is a possibility of getting better. Sometimes when we're in pain all the time, it can feel hopeless, but keeping track of those minuscule changes can be really helpful, because maybe my pain today is at a 7, but yesterday it was at a 10. And so that's progress. So that's a little bit about how I inspire some hope.
Just from a behavior change standpoint, to kind of piggyback off of what Marisol said, I think just really reinforcing the positive behavior changes and choices that people are making to help cope with their pain. Just showing up to OT or PT or showing up to their appointment is sometimes challenging in itself. So just reinforcing those positive steps that people are taking, and understanding chronic pain and understanding CRPS. I think just creating a space where the patient feels heard and understood is really important for inspiring hope. Sometimes when they come to us, they've been to a number of practitioners and it's the first time that they feel heard. So that's really important. And then I think, like I said previously, just connecting them to other community resources and support groups where they can hear other people's stories is another way of creating that sense of hope.
I'm gonna jump in. The first thing I do with people is I listen to their story. And normally halfway through, I put away my computer, put it off to the side, listening, and we just have a conversation, because I want to hear their experience. I'm not just concerned about documenting what's going on, but I'm concerned about how is this affecting their life? How is this affecting their loved ones? How is their life? How is that impacted? And when they understand that I care, that makes a big difference. Then I am confident because I've been treating it for a while, and show them that I have a plan and say, hey, we're going to go from here to here to here to here. And when they hear, oh, we have this plan to move forward, that's really helpful.
I think CRPS patients have a whole world ahead of them. Keep looking to see what's bothering you. What about the CRPS symptoms is the most bothersome? Is it the specific pain? Is it the area of the pain? Is it what it causes you? What it causes you to have emotional changes? Talk about it and look for answers, and definitely get into support groups and talk to your care people, healthcare providers, and look for solutions. There is a lot there. There is definitely no need to be suffering unduly. Unfortunately, you can't get away from it too easily, but you can have a good life.
In addition to everything everyone else has said, something that I like to do with my patients is go over all of their previous treatments and go over treatments that they haven't ever experienced or maybe ever heard of. I have patients who've never heard of ketamine infusions. They've never heard of spinal cord stimulation or neuromodulation. And when they come in, they've tried 7 nerve pain medicines, but they've never heard of these other treatments that are out there. So we go over their previous treatments and we talk about, what dosing or frequency of the medications they've been on, like was said earlier, maybe they weren't optimized on the right dose or the right frequency. Maybe we revisit those medications, maybe we don't. But we talk about all of the options from, medications to procedures to, mindfulness techniques, biofeedback, cognitive behavioral therapy, all of those things. And I list them out for the patient because then it can show them how many more options that they have in the future.
So to echo what a lot of other people have said, something I like to do just with patients that I know are really struggling with a chronic disease is just give them an extra bit of my time. We have a lot of constraints on our day as physicians. We have to write notes, see patients, do everything in a timely manner. But if I really feel like a new patient has been through a lot and I kind of can tell that they've been to a number of physicians and they haven't always been listened to, then just sort of trying to build a relationship of trust. And then the same thing that we spoke about before about like presenting options, letting the patient choose. But I feel like they feel a lot better moving forward with someone that they know cares about them. And so it sets like a good physician-patient relationship from the very beginning.
One thing I like to do, or I end up doing, well, first of all, I completely agree with what Marisol was saying, that, if you can notice the changes that are happening and have the person really be aware of what the improvements are, that's always very, that always contributes to a greater sense of hope. The other thing I like to talk about is that, improvement is not linear. So what happens is, people start to come in and then they're improving and they're really excited, and then they have a bit of a setback. And that kind of creates a real fear that, oh no, it's not working, I'm not going to get better. So we try to talk about how improvement in anything, particularly in any kind of pain or medical, it's not linear. It kind of goes up and down, and hopefully at the end of it you're more up than down, but it's not going to be a straight line. And that helps them, start to regulate their feelings when they start to see that they have a little more pain, and not to go into a state of hopelessness and helplessness.
I think one common theme that we're all sharing is the continuity of pain, and understanding that we as providers are much different than your typical medical practitioners who treat a specific condition with objective data and findings. When you go to an orthopedic surgeon for a fracture, that fracture will be treated, and when you return with pain, they'll tell you, go see a pain doctor. One thing that you'll never hear in my practice is go see a pain doctor, because you're seeing the pain doctor. So understanding that there is a continuum of pain, and so the fluidity, as Dr. Cohen had mentioned, is critical. We won't say that the spinal cord stimulator, the hardware looks great, I don't know why you're having pain. We're going to really dive deep to make sure that there's not a hardware issue. We're going to optimize software programming. We're going to do everything that we can to ensure that you have a safe haven to seek treatment when that pain flares. I can't tell you enough how many times I have patients in my practice who come see me as a social visit. There's no prescriptions being given. There's no reprogramming of stimulation being done. There's no blocks being recommended. We're there to purely discuss how their progression of their disease is. And when things are going great, that discussion happens 3-6 months. However, when you get lost to follow-up, so sometimes patients do extremely well and they'll go years, and they'll return a year later and say, this isn't working, that's not working. And I'll say, I haven't seen you in a year. Let's start from the beginning. So expectations are really critical and important. And also follow-up care is really at the crux of a chronic pain conditions journey.
I think it's crazy. I'm sitting here and I'm getting incredibly emotional listening to this, because I'm sitting here in my home, but there are 10 people who've said the key words that I myself have not experienced since my diagnosis, and is, I'm willing to listen, I care, and I'm willing to sit down and take the time to take care of you and pay attention to you. And I think that is what is most important. Like every one of you hit the nail on the head. And it's amazing how much difference that makes as a patient who can go to someone and they're just willing to listen. I don't even need you to fix it necessarily. I just need you to listen and to hear me. And I think that is, if anything, that is anybody has said today, that is the most important part right there. So
And Dr. Goldin, that may, I apologize, I think I interrupted. Go ahead, I'll finish.
No, I was just going to end it really by saying that I really appreciate everything that everybody has said today. And it brings me so much hope to hear that there are this many people willing to just sit down and listen and hear what a patient has to say, you know, so we'll go ahead. What were you going to say?
Yeah, but you said something very important, that pain patients need somebody to listen, that listens to them and validates them. So to you CRPS patients, look for that kind of people that can sit down and listen to you, not only the healthcare professionals, which is critical for your healthcare professional to validate you and listen to you and not by any chance mock anything, but also family members, friends, clergy, anybody you have, you can use them too.
Sure. Yeah, definitely, it's true. But I don't have any more questions, but I really want to thank everybody for their input. I think this has been really helpful and full of a lot of information for everyone. And I'd like to thank you all for participating.